Welcome to Adapt NCLEX, and thank you for deciding to watch this video. This is a series we've been doing on musculoskeletal. We talk about cast, we talk about different kind of fractures, we talk about splint, we talk about traction. Those are our bridge for a definitive treatment, and definitive treatment is surgery. If you need surgery, what kind of surgery? The first one, open reduction internal fixation. Look at the name. The name give it away. Open, I got to see something, and then internal fixation, I got to fix it. You can see there's incision, there's a rod placed, everything is closed, and you take a picture. Here's what you look like. So what does that mean? It's a surgical procedure where a fracture is aligned. You make incision, open reduction. That means you make incision through the skin, get to the bone, put some rod in it. Bone is held, mostly will be held in internal fixation devices like a screw, like a plate, like a rod, like a pin. And then you close the skin. And then this is when you take an x-ray, this is what it look like. When do you use this situation? Complex fractures that is so bad that cannot be aligned with just a close reduction. That means you pull it in place without making incision. Or fractures that involve some joints, or fractures of the long bone, like femur fracture, humerus fracture, right? Fractures that involve significant soft tissue injury. That means the skin has been broken, there's a risk for infection, and then the fracture is unstable. Those are indication for open reduction internal fixation. Based on the procedure, you know what you're supposed to look for post-op. Monitor for signs of infection at the pin side, right? Or the incision side, sorry. And check neurovascular check every time. No matter what kind of surgery is done, neurovascular check. That means you're looking for blood vessels going through there, and you're looking for nerve function. And early ambulation, because you got to gain your activity back. But it's depend on the provider. You cannot just get a patient out. You have to know what is prescribed for the patient. They need some pain medication when you're dealing with the bone, and teach them about weight-bearing status as provided. If there's toe touching, they touch their toe. If they have to be completely non-weight-bearing, they have to be completely non-weight-bearing. So these are things you have to tell the patient to do. You can't just not get the patient out of bed. So if they have surgery and they want to get out of bed, the next thing you should do is to check the weight-bearing status. That is number one. Number two, close reduction internal fixation. As the name says, if it's open reduction, I have to make incision, where close reduction means I have to just pull the bone, align it without making incision. Then I have to stabilize it by doing external fixation. So that is the X-fix you can see. So this is somebody's hand that is broken. It's been pulled in place, but then we put an external fixation, not internal fixation. So you're going to see the rod outside the skin. That's what it means. Close reduction, external fixation. Involve manipulation of the bone. So you crack the bone in place without surgery, and you restore alignment. Then you got to stabilize. Instead of casting or putting in traction, you put an external fixation in place. So application of what? External fixation device to stabilize the bone fraction. Indication, open fracture. Look at it. Open reduction, you got to make incision, right? But if the skin is already broken, already traumatized, and there's more risks of infection, you don't want to close it. So you're going to use external fixation, close reduction, align the bone, put the external fixation there, and treat it with antibiotic rather than trying to close it. It's going to get infected. And if there's a massive soft tissue damage or the risk of infection, external fixation is better. Post-op management. Still, you got to worry about infection. Pin site is critical to prevent infection because it's going through the bone. It can cause osteomyelitis. Teach the patient how to clean it. You just use saline or antiseptic solution, chlorhexidine, but you should never use hydrogen peroxide. Assess for signs of infection like redness, drainage, increased warmth, anything that sounds prevalent, right? Educate the patient about the importance of not manipulating the external fixation. You can't change it. You too, you cannot manipulate it. You can have a wrench available at bedside, but you should not adjust the height or adjust the screw. Leave it to the doctor. And of course, compartment syndrome and neurovascular check. Intramedullary nailing. That means you're just nailing the bone in place. You put in a nail through, and that is all you need to do. Usually very small fractures or long fractures can be used. Like a metallic rod, a nail is inserted intramedullary cavity of the long bone and left in place to stabilize it. And this is specific for like diphasal fracture of the long bone, like a mid-shaft area, or if it's completely comminuted, it's shattered in place, you can nail it in place. Post-op care, the same thing. There's a needle, worry about infection, ensure early mobilization to prevent DVT. Of course, we're dealing with the intramedullary. So when you go into the bone, deep layer of the bone, worry about fat embolism, pain management, and weight bearing status. It's still the same. Bone graft means the bone is so shattered, we got to bring, or it's not healing well. Like you have a non-union of bone that is not healing, it has a bump, no matter how you align it, there's still no healing. You got to take the whole bone to bring another bone to replace that portion of it. Post-op management, that means after surgery, what do you do? The nurse monitor for signs of graft injection, or monitor for pain medication, graft infection, and get an X-ray to make sure everything is working. We all know about knee replacement. Sometimes they use the word arthroplasty. It's a plastic, like facial manipulation, like plastic surgery. You shaping it in place. So arthro is a joint, right? Plastic, you shaping the joint in place. So it's a joint replacement. It can be knee or hip, right? So what is the indication? Severe fracture of the hip, whether the knee or the femoral neck, right? Or the joint is completely destroyed by rheumatoid or osteoarthritis, mostly osteoarthritis, that will require replacement, right? Because rheumatoid deal with the small joint, osteoarthritis deal with the large joint. So most of the time, large joint replacement, like the hip and knee, by osteoarthritis. It's a big surgery. Worry about getting out of bed. You have to use crutches or walking. They cannot leave the hospital without not walking, but they should not leave with the wheelchair. That's the thing. They can go on with the walker and crutches, but not with the wheelchair. You should be walking after hip arthroplasty or knee. Monitor for DVT, okay, and prevent dislocation, right? Sometimes you use something we call abductor wedge. Put the legs away, abductor, not adduct. Adduct means you harden them together. We're putting the joint away. So we put an adductor wedge in between. So the legs are far apart. You can place a pillow in between and you can push the two joints, two hips apart. Okay, they should not cross their leg. Okay, they should not bend more than 90 degrees. All these are all teachings you teach them so that they will not prevent dislocation. Crossing your leg, you should not put a pillow under the knee if it's a knee surgery. These are all very important. And physical therapy is very good. But that's the key things you're supposed to know. In summary, infection, heavy orthopedic surgery, whether it's ORF, external fixation, worry about infection. If they have a pain, teach them how to take care of it. You need to do neurovascular check and your 5 Ps in order, or your 6 Ps also, in order to make sure there is no compartment syndrome. And of course, DVT, pulmonary embolism is something you have to know. So early ambulation, but make sure they have prescription to get out of bed. And if they need anticoagulation, you give them. Most of them, early ambulation and anticoagulation is your key to prevent DVT. Weight-bearing status. Like I said, patient need to adhere to the prescribed weight-bearing status. Whatever the doctor say, whether it's full weight-bearing, partial weight-bearing, you should be aware about it and teach them how to use the crutches, the walk, and the cane. This is how your fundamentals will come in. You have to know how to teach them. And of course, post-surgical complication, fat embolism, and compartment syndrome. So these are what the NCLEX like in terms of after surgery, infection, neurovascular check, DVT, PE, weight-bearing status, and then surgical complication. These are your big eyes, compartment syndrome and fat embolism. Thank you for watching and have a good day. If you need more, subscribe to Adaptant Plus, click on the link below and join the membership, or you can just watch free video and you'll be golden. Keep charging as always. Bye.